The learning goals of this chapter are to demonstrate skills needed for advanced practice nurses to advocate for consumers, families, and public policy change, the role of health and wellness as a model for advocacy, and examples of advanced practice nurses as advocates for change within the healthcare system. Advocacy is to act for, speak for, plead for, or defend. This can be described as informing, advising, or counseling. The American Nurse Association defines advocacy as the act or process of pleading for, supporting, or recommending a cause or course of action. Advocacy may be for persons or for an issue. Advanced practice nurses occupy middle ground between the consumer and the healthcare system. They are in an optimal place to mediate. Historically, advocacy has been linked to the potential powerlessness of the patient. We should distinguish advocacy from paternalism and consumerism. Paternalism is the commitment to make decisions for the client or patient because of the professional is obligated to impose expertise on behalf of the person in need due to their level of expertise. So think of early patient-provider communication. It was often more paternalistic instead of a shared decision-making model. You think of the old-fashioned doctor who just came in and told what the plan of care was, and this is paternalistic, kind of seen in more of a fatherly figure, and they were not shared with the patient. In contrast, consumerism is on the opposite end of the spectrum. It is a commitment to remain uninvolved in the client's decision. In this context, a person is presumed capable to make self-determination. Advocacy lies between paternalism and consumerism. The advanced practice nurse who is an advocate uses a shared decision-making model that uses expertise to help patients make complex decisions for their health care. Let's do a knowledge check. Which of the following terms best defines the active process of pleading for, supporting, or recommending a cause or course of action? Advocacy. In this scenario, what differentiates advocacy from paternalism is the act of pleading for a course of action. This is providing information for the patient to make the final decision. In a consumerism model, the patient would independently make the decision. The paternalistic approach, the provider would make the decision without including the patient in the process. So as a clinician, I have actually used all three approaches with patients: paternalistic, advocacy, and consumerism. I find which type I use with communication and also with advocacy roles and decision making depends on the severity of the situation. So basically, oftentimes when the outcome doesn't matter, I take a more consumerism approach. And then when the outcome has high stakes, I might take a more paternalistic approach. I currently work as a midwife at the University Hospital. When it comes to the mode of delivery, I take a very consumerism approach. Many patients have researched different modalities for delivery and come to my unit with a labor plan in place. For these decisions, I remain uninvolved to the client's decisions as long as they're safe and well thought out. There are some interventions within my clinical practice that I use a more shared decision-making model. In this role, I am an advocate. A patient who presents with gestational hypertension, I may encourage to be admitted for medical induction. I may even plead the benefit of the induction, but ultimately the decision is up to the patient, even though I have recommended a course of action and provided evidence for this course of action. There are some times in my clinical practice when I take a very paternalistic approach. These are usually times when the stakes are very high and a shared decision-making model will not work. For example, a patient who presents with severe preeclampsia with severe features and seizures will not share in the decisions. At this point, I will make the decisions for them within my expertise as a clinician. So I will start the magnesium and start treatment to help prevent seizures and stroke. And then later on, as they're in a better place, we can have a more shared decision-making model. A newer model of advocacy is health and wellness coaching. In this model, the advanced practice nurse works as an advocate by teaching clients to become advocates for themselves, for self-care, and also how to navigate the complicated healthcare system. View the advanced practice nurse in this role and in this model as a health coach that coordinates care and uses their advocacy skills to help the clients negotiate the system. In this model, the advanced practice nurse teaches the patient to become the advocate. It is a very empowering role. View this newer model as teaching the patient to fish, right? That old adage, if someone's hungry, give them a fish, but if you want to feed them for life, teach them to fish. This type of advocacy is teaching the patient to be their own advocate. And I think in the long run, this will have better healthcare outcomes. Client-focused advocacy will focus on the individual patient and their families. The most dominant model for patient advocacy comes from the counseling paradigm. The counseling model is the mainstay of advanced practice nursing. This moves away from the nurse protecting the patient to a system of consumer empowerment. Consumers do not seek the paternalistic approach from the past. They want a professional, advanced practice nurse who can help them navigate the system and provide them the education they need. The skills needed for the modern advanced practice nurse in this role include being empathetic. They are listening, they're self-confident, they have assertiveness, negotiation, collaboration, communication, physical assessment, mental status assessment, crisis intervention, case management, change in agency, and teaching. I kind of view the type of nurse practitioner who can be a consumer empowerment type as one who has a leadership style that is transformational. He is basically sharing a vision with the patient and then helping them advocate for that vision. We are going to talk about advocacy on different levels. One of them is the advocacy exemplar. And the nurse advocates in work that is in a consumer organization. And this model of advocacy, the consumer is an expert, and advocacy is a partnership between consumers and professionals. Advocacy is an activity that is not owned by one sector of healthcare in this model, but multiple modalities. So when you think of an advocate, this could be many types of healthcare professionals, from physical therapists, occupational therapists, to the nurse at the bedside. And advocacy will call for the development of creative strategies. So I love this. Sometimes there's different ways to do things than we thought of. And these are kind of some of those changes that we talked about previously. As we think of new ways to be creative, we're going to come up with better solutions for our healthcare system that is already costing too much money. So let's talk a little bit of example of a nurse in the advocacy exemplar role. So one of them is the CARE Act. So AARP performed a groundbreaking study years ago that assessed the strain of family caregivers. So basically AARP surveyed family caregivers across the country to get a look at what type of help they were providing when their family members went home. And they found that they were providing much more complex care than previously thought. They were managing complex medications and wounds, and basically what families were doing at home was more than had been previously thought. Most families were actually performing in some kind of a medical nursing tasks. They did not get any training for these tasks, and most did not have any home visits by a healthcare professional. Family members reported being stressed performing these tasks because they were undertrained. More than half reported feeling down and depressed. In response to this study, legislation was passed to help family caregivers. The type of people who help pass this legislation are examples of advocacy exemplar nurses. What was passed was what's called the Caregiver Advice Record Enable Act, or basically CARE. This requires hospitals to ask patients to designate a caregiver to notify the caregiver before discharge, and then to educate this caregiver in the medical nursing tasks they will be expected to perform. The implementation of this act, however, has been uneven, but it is a good example of nurses that have worked as advocates as they work for legislation to increase caretaker education and hopefully decrease caregiver strain. I want you to take a moment and pause. Think of the skills you will need to be a patient advocate. When I think of skills that I need, I think of being an effective communicator, being politically active to help elicit change within my sphere of influence, being a good educator. I view my role as an advocate as providing expert opinion and helping the patient make decisions and supporting those decisions in their plan of care. And that's on the individual level. On a systems level, I view my role as taking my knowledge within healthcare and bringing it to a legislative level and helping to advocate for changes within the healthcare system to best protect and support my patients. So far, we have been discussing advocacy and nursing on the individual and family levels. And advanced practice nurses, I think, are some of the best advocates on that level, because as we take care of patients on a day-to-day basis, we see how they're affected mostly by their medical illnesses and conditions, and we can see what their needs are. So we become great advocacies. However, I want to talk about advocates on a policy level for populations and community. Advanced practice nurses that are doctorally prepared should learn additional strategies to become advocates, such as preparing a position paper on policy, to implement and advocate for healthcare policy and address social justice, and to educate to engage in a system-level advocacy and engage in political action. Systems-level advocacy and nursing practice at the population or community level is public health. Public health nurses think of this as upstream thinking. Let's take an example from our text. A provider could treat a patient for lead poisoning. They could help the family navigate the system. They could help the family do better. But ultimately, they're not preventing anything. They're helping one family. Upstream advocacy would be to prevent lead poisoning through policies and programs that abate all houses with lead paint. Advocacy skills they need for community levels are insight to problems on a systems level, communication skills, active listening skills, and verbal skills. These advanced practice nurses need to understand program and policy development. These again are the type of leaders who can look at systems. Let's talk a little bit about how to be effective on a systems level. The advanced practice nurse needs to understand the program and the policy development. The stage sequential model described by Hanley can guide this process. The first stage is to identify a policy problem and get that problem placed on the policy discussion and action agendas in the appropriate form. So think about this as, is it a school problem, so it goes to the school board? Is it a state problem, so it goes to the state board? Or is it a federal legislative problem? So you're going to first identify within a social system a problem and then find who you bring this problem to. The next step that follows are to develop policy and options with the supporting budget, infrastructure, and regulations. So first you're going to identify a problem. Second, you're going to bring this problem to the legislature that it's connected to. And the third, you're going to think about what are we going to do to solve it? What are our options? How much money does this cost? What infrastructure needs to be in place? And what regulatory guidelines would help? Lastly, there's program implementation and evaluation that are the final stages. Moving through these stages requires an understanding of the change process in general, with skill development in creating a sustainable vision of the changes. I would like to discuss one of my own experience with trying to advocate for change on a policy level. 10 years ago, as an undergrad, I went to Washington, D.C. to discuss reform on prescribing opioids. Now, I have to bring you back to a different culture in medicine. Back then, pain was the fifth vital sign. Whatever a patient said their pain was what they were. So if you came in and a patient was passed out on a bed asleep and they said, I'm out of 10, you would get out the Percocet. So at this time, healthcare professionals started realizing that we were over-prescribing opioids. And remember, there's some political things going on with the opioid companies, right? Some of these pharmaceutical companies had a lot of lobbyists in Washington. And I think way before the opioid crisis or epidemic, healthcare providers noticed that there was a problem. So I went as part of a nursing organization, and we went up to Washington and we asked if we could basically identify a problem, and that if we could put in some legislation that would put some restrictions on educating prescribers who are prescribing opioids to help them be better informed. Now, honestly, this was prior to the opioid epidemic, and there wasn't much buy-in to Washington. There was a lot of lobbying for pharmacies, and this was not one of them. So as we proposed a bill, it actually didn't make it, and it didn't pass. So where we were on these levels that Hanley can guide is we made it to the first step. As nurses within the healthcare system who were on the front line, we were able to see that opioids in general are being overprescribed and that there were some problems from this. However, we brought it to the right form, which was on a federal legislative level, and it was not passed. So the next step was stopped. We were not able to find an infrastructure or legislation or supporting budget to make the next changes. And this is like an example I want you to think of when you're really trying to elicit change, that you can sometimes, if you do one stage, like you brought it to the legislative, maybe if it doesn't pass, you go to the next stage. So the next steps would be to go to a state level. You go, okay, the federal legislature isn't buying in, but on a state level, we can buy in. Now, if the state doesn't buy in, I would even go to your institution. Go to your hospital and say, hey, we're over-prescribing these medications. I don't think women post-cesarean need 20 Percocets. And this is kind of showing the stages of change. You start within your power of influence and keep moving from there. Let's do another knowledge check. Which of the following is the type of advocacy nurse practice at the population or communication level? Okay, systems level advocacy. A systems level advocacy is when nursing practices at the population or community level. Let's take a moment to reflect. Can you think of a public health concern in your community? Can you think of a systems level advocacy strategy to address this concern? An example of this could be contacting a legislator with a writing campaign. Can you think of other strategies to be an advocate on the policy level? It could even start as just meeting with your nursing organization and finding what options there are. It can be a day at the Capitol. I know within Utah, women's access to reproductive services has always been a major issue. And one of the things you'll see is people who feel strongly about it wrote a letter. All the maternal fetal medicine doctors within the state did a policy letter that they presented to the legislature, and providers within the women's healthcare system at the University of Utah Hospital and also other healthcare providers within the state of Utah attended a day at the hospital, the day of the legislature, where they just discussed the issues of women's health and what access to care looked like for women in Utah. So these are ways to make people more aware. So sometimes it can be small things. If you don't know where to start, it might just be starting with a letter. If you look back in your text at Chapter 6, it will describe the statutory and regulatory barriers to advanced practice nurses' practice of care. The first recommendation of the 2011 Institute of Medicine report asked to remove scope of practice barriers to enable advanced practice nurses to practice to the full extent of their education and training. This has helped remove state and federal barriers to advanced practice and care. The Campaign Action website details progress that's been made in removing state and federal barriers. This is a website that you can become better at, where you can become a better advocate of practicing at the top of your license. At the end of this chapter, I'd advise you to look at the end of chapter 14, and it has many websites that are different ways that advanced practice nurses can become advocates, and you want to be your own advocate and advocate for your licensure so that you can practice at the top. So if you think about this, when I started practice in Utah, we used to have to pay a doctor to just once a year, they would sign this sheet of paper saying that they backed you up, and you'd put it in your office. And basically what happened was it was just a way for these physicians to make a fee for service. They never read your charts, they never participated, but they would charge you like $2,000 or some funding to sign this letter. And so recent legislation has moved away from this, allowing nurse practitioners to practice more independently and keeping us from being taken advantage of in more consumerism type models where you're paying for a doctor to sign a sheet of paper who is actually not overseeing your patient care. So these are the reasons why we want our advanced practice nurses to be good advocates. We want you guys to have a seat at the table and to grow our field. Advocacy is an important skill for the nurse and the advanced practice nurse practitioner. How does the beginning advanced practice nurse become an advocate? The expert nurse can learn advocacy skills through regular dialogue with other members of the nursing community, the patient and patient's family, and other clinicians. New advanced practice nurses need support to take on this role. I think it feels vulnerable to go ahead and be that advocate for a patient, and certainly to be an advocate on the policy level. Role modeling is one of the ways that we can also provide a positive learning environment to help the new advanced practice nurse gain confidence to advocate for patients. Let's do another quick assessment check. How do nurses learn advocacy? There are many ways you can practice advocacy skills. Can you think of some? I like this answer because they say advocacy is learned by watching other nurses interact with patients and providers. Some of the other ones were true. Modeling does work, but it's not the only way. Nurses can learn how to advocate by watching other nurses interact with patients, providers, and by working with mentors. Role modeling and dialogue provide opportunities for positive learning experiences. I was thinking of an example from last night, actually. I was working with a brand new midwife. We were at the ER, and this patient had a category 3 tracing. So in the land of obstetrics, she was 42 weeks with a category 3 tracing. That is the type of tracing that needs an immediate delivery. She had consulted, and the consulting physician was a family practice doctor who said that they felt okay with the tracing and wondered if we should do a fluid bolus and see if we could get this patient home. So she looked at me nervously, and I could tell she had not ever been in this position where her consulting provider made a choice that she would disagree with. And so one of the things I decided to do was that I would role model the dialogue as a way to help her. So instead, I called back the family practice doctor, and just said, "Hey, this is Lauren with the midwives at Obis Emergency. We talked previously about this doctor. I want you to know that I'm going to go ahead and just consult with one of the maternal fetal medicine doctors because I'm concerned about the strip. And I just think it'd be great to have another set of eyes." And then this doctor agreed, and the third doctor looked at it, and we all agreed to actually emergently suction this patient. But what was good about this modeling is sometimes you can go above someone's head in a way that doesn't feel confrontational. And I felt like that conversation modeled a good way of becoming a patient advocate. It's being vulnerable. It's telling someone in a position of authority over you don't quite agree with their plan of care, but it can be said in a really professional manner. So when I said, "Hey, I would like to just consult with maternal fetal medicine and get another set of eyes on this tracing. I think it warrants maybe another set of eyes." That is a really mellow way of saying, "I'm going to call another expert because I think your opinion's wrong." And then at the end of it, she felt much more relaxed, and she told me she didn't know what to do. But after we had talked to the maternal fetal medicine doctors and were able to transfer this patient, and we got along well with the family practice doctor and there weren't hurt feelings, she realized that many times you can be an advocate for your patient but still have respectful communication. So when you're in a more advanced role and you're a nurse practitioner or nurse leader or charge nurse, I think modeling for the younger nurses how that communication looks is important. And I think it gives them the language and the ability to make those same conversations. And another thing I thought was important was when we modeled this language, I think it's easy to do what I call the back talk consultation. And this is where everyone's like, "Oh, I can't believe this family practice doctor thinks this tracing's okay," and everyone's upset. That was not the role. I just said, "I see your concern. Why don't we talk to somebody else?" and only involve the people in the conversation who needed to be. Less drama and then more patient safety. And I think modeling this behavior on the unit becomes key, especially when you are teaching new providers the culture of a unit. All right. Thank you guys so much. We're going to move on to the next chapter. If you'll look ahead, we're going to be looking at chapter 22. All right. Chapter 22. The objectives are for the learner to be able to describe existing and emerging technologies available to advanced practice nurses to enhance clinical practice, develop an understanding of health information technologies that are available, to demonstrate the ability to evaluate and utilize different electronic patient record software, and finally to understand different types of health information exchanges and how they are utilized in clinical practice, and how to utilize high fidelity simulation as an educational technique to train student advanced practice nurses. Electronic health records can be shared among providers and patients. The goal of the electronic health record is to improve quality, safety, and efficiency of healthcare. The Agency for Healthcare Research and Quality focuses on strategies to secure EHRs and how to use health information technologies to improve quality and cost effectiveness in the management of individuals and groups. During the Obama administration, the American Recovery for Reinvestment Act of 2009 established the Office of National Coordinator for Health Information Technologies, or better known as ONC, into law. The adoption of health information technologies in the United States has been augmented by MU, or better known as Meaningful Use Program. This program offers financial incentives to improve health information technologies. You may hear at your institution of practice phrases like, "This is meaningful use money." This is basically financial incentives to better utilize technology within your healthcare system. So within my healthcare system, we decided to make it so that patients could email their providers and get sent their actual records. And this was an example back in the Obama era of using meaningful use money. We were given incentives as we brought this new technology into practice, and the incentives paid for the upgrades. So it was basically the federal government's way to incentivize us to better use electronic health. The next two slides are going to just review the essential objectives of the Meaningful Use Electronic Health Records Incentive Program. I'd like to kind of go over what actually the Centers for Disease Control 5 main objectives behind this program were. So first of all, they want to improve the quality, safety, and efficiency, and to end and reduce healthcare disparities within the system. They want to increase patient engagement, improve care coordination, expand population and public health, and ensure adequate privacy and security protection for health personal information. With these priorities in mind, the CMS and ONC established meaningful use standards that electronic health records needed to meet. If CMS determined that a successful demonstration of meaningful use applied, the parties were considered eligible for federal funds. Because the Meaningful Use Program was voluntary, meaningful use criteria were considered guidelines, not regulations. They weren't regulatory. But basically, if you failed to adhere to meaningful use, you resulted in reimbursement-related penalties. So if you didn't meet the guidelines that the federal government had come up with to improve healthcare systems, basically you weren't going to be awarded the federal funds. So my institution of practice utilized meaningful use money through using electronic medical records for patients to communicate. We talked about this previously. This is a great example, and it improved care coordination, and also it increased patient engagement. So when patients can, if you think about a complex treatment plan, when you review with a patient a very complex plan, and they are able to go ahead and read back on your plan, there is much better buy-in. The patients do what the plan was. How many times do we meet with a patient who has many complex issues going on and discuss several plans, and they probably really don't remember what we're telling them? I think they get like a third of the visit. So if we are able to give them access through electronic health records through a portal, like a patient care portal, where they can read the things that were said, especially when they have complex medical conditions with a multitude of healthcare professionals managing them, that really increases their buy-in, and it really increases their ability to adhere to the plan. So this is a great example of using meaningful use money to help get some of the objectives in the incentive program. So looking back, I don't think this is in place anymore, but looking back, what have been your experiences working with electronic health records in practice? And these experiences are going to run the gamut. You have doctors who think the worst thing that ever happened in life was that we went to electronic health records. They miss paper charting, which I've never missed, to be honest. And then you have people who get frustrated because from hospital to hospital, there's different electronic health records. So for example, I have used Cerner, I've used Epic, and I've also used at Planned Parenthood, we used a IT program that was really, really rough, and it was an off base of a Cerner platform, but it would use like 12 to 15 different templates to get through a visit. So my experiences with the electronic health record have been from the electronic health record ease practice to one where it became a distractor. And my experience is the more work put into the platform, as in the more ways as providers that we sent feedback to the people who developed it, the better it was used for our modality. So at OBS Emergency, it is really smooth. The electronic health record really facilitates safer patient care. But part of this is every 3 months we've worked with IT to change the system, to change the platform, consistently tailoring it to our needs. And now it is a very good system. In my other work environment, we did not tailor it. It was tailored for a national system, as in our Planned Parenthood in Utah. the same system was used as the same one was used in New York. So we would have different services that we weren't offered. Like we didn't offer prep service in Utah that was being offered in other affiliates, but we were having to go through templates of their charting for things that we weren't doing because we weren't able to tailor the electronic health care system to our individual practice. So I think you'll find some of the programs are more tailorable. So like Epic is one of my favorite ones, and that's a bias I have, but it's used in pediatrics all the way to adults. And part of the reason is how that platform works is you tailor it. So if you're in peds, you're not going to put the same templates that I use in an adult emergency department. But if you don't put the time into tailoring it for your unit, then it's not going to meet your needs. So sometimes how smart a healthcare system's electronic healthcare system is dependent on the users. Electronic health records are systematic compilations and management of patient health information. It can be shared with other providers and across healthcare systems. So the benefit is I'm able to summarize my visit in Utah for a patient who's seen in California and send them this information. The goal of the electronic health record is to improve quality, safety, and efficiency of the healthcare system. The electronic health care record basically facilitates information sharing among providers and between providers and patients. With the provider-patient electronic health records, patients have better access to their health records, including medical information, laboratory results, summaries, and plans. Think of working a complex plan of care like we mentioned previously. Retention to that plan is going to be increased as a patient is able to access and review that plan of care. There are some institutional benefits to using electronic healthcare records. Among the clinical benefits of EHRs are to have tools to increase the provider adherence to evidence-based guidelines and to reduce medication errors. Specific EHR functions as e-prescribing, built-in alerts, patient access to healthcare records, and organizational benefits have a cost savings and accuracy in the billing and coding. I think there's a lot of benefit in billing with an EHR system that paper charting didn't quite have. There are also some disadvantages to the EHR. There are some costs to adopting the system, the cost to implementation, adoption, and maintenance of the program. Some problems of the implementation of an EHR are lack of training and competence among users and possible threats to privacy and security of the EHR. HIPAA has expanded its privacy and security rules to adopt national standards for electronic health care technology. With the emergence of many new types of technologies, there are many opportunities for potential breach of privacy and safety when providing care to patients. Each institution now becomes responsible to protect patient health information with using technology. For example, my institution of practice, when emailing about a patient, the byline must say PHI to protect the information. Can you think of ways in your healthcare facilities and places of practice that information is protected within your current clinical practice? I was thinking of actually another example of an information breach. When I worked at Planned Parenthood, we would have people try to hack into our system to get patients' names who had had abortions so that they could print off these lists and publish them. So there was a major burden when there's even predatory people trying to get patient health information for that institution to make sure they have the correct firewalls and IT in place to make sure that we could keep our patients' confidentiality and that we could keep HIPAA. Because it's a basic right for patients that they can keep their privacy between their providers. As mentioned before, there are some threats to electronic health records that emerge because of transparent security measures and poo-poo password management. So I guess what I think about with that is, have you ever had that password that you used in high school and you still use today? That's not really protecting your patient's care. One of my favorite IT guys told me to come up with a crazy sentence and use each letter. Like, I like to go to dinner on Mondays, and use the first letter of each one of those words, and it makes a more secure password. Another way that advanced practice RNs can help ensure patient privacy and security is by using predetermined secure passwords. Sending email or text only if there is certain that only the recipient has access to the account, and following up when there's a belief that there's erroneous information. And also participate in professional development. Within my organization, every year there's development that talks a lot about electronics and how to do HIPAA. For example, computers that are used in the hospital and at home have to be sent to IT, and basically they put some type of coding on there to keep it from being hackable. Emails have to be sent with a PHI, and also patient information isn't shared on a home basis. So as we have better access, like I think it's nice to be able to chart at home, but it's also important that that access to that EHR in the home setting doesn't lead to patient's information to being not protected. All right, let's talk about health information exchanges. This for me is like the biggest dream. I work in an ER and I have these patients come from several of the surrounding states, and they come in like a big box of I don't know, and there's so much information I need within their management, and getting their records at 2 a.m. becomes such a challenge, especially when I have a patient from a rural area where that one on-call doctor doesn't answer his pager till 6 a.m, and there's no way to get the records because they're paper until the office opens at 9 when someone will fax them to me. And it's 2 a.m. and we're making a critical decision. And what I know is I'm going to repeat all the labs, all the ultrasounds, and we are going to cost a lot to the healthcare system because I can't wait till 9 a.m. to get this office in Wyoming to open up its office. So I love the idea of health information exchanges. This is the ability for everybody to use electronics and to send information across through electronics. And it would really decrease costs within the healthcare system, because I know as a provider personally, I order things that I know have been ordered all the time because I cannot wait for the information. It is information sensitive decision making. So the labs are being rerun, the ultrasounds are being reperformed, and it is costing the healthcare system a lot. The goal of a health information exchange is to provide coordination of care in an effective, efficient manner. There are 3 types. One is direct exchange. This is where providers receive and send secure encrypted patient information. So within my stay, I'm able within my own organization to have direct exchanges, but also another one of the major companies in the state of Utah, which is the Intermountain System, has created what's called Epic Everywhere. They use a different system than us. I think it's Cerner, but it's a Cerner-based system, and we use an Epic system. But basically, I can directly see their records. Now, generally, it's 2 to 3 days behind, but it is much better than not having any records. So it's a direct form of communication between our company and their company when we're managing each other's patients. And many times we are, because the university hospital will do the deliveries for the high-risk babies that have complications, and those babies will always go to the Primary Children's Medical Center, and that is run by IMC. So those 2 companies have figured a way to have some direct exchanges for these situations. The next one's interesting to me because it's a query-based exchange. This allows the provider to discover health information about the patient, and it's usually unplanned care such as an emergency room. Now, for my patients who are like in Wyoming and different places, I find most of my information I find through a health information exchange is query-based. I might see that they saw another ER, like I'll be in ER and I'll see that they were seen in an IMC ER, and I can see their records, and I can see their records from urgent care. What I can't see is their actual prenatal care, but I'm able to see kind of what emergencies they've had in their pregnancy. And then finally, it's consumer-mediated exchange. So this is my favorite thing, is when a patient comes, I have no records, and they're able to get into their Help 2 or their basically MyChart access, and I'm sitting there with the patient in their room looking at their cell phone, and we're looking at their healthcare information through their patient portal. So that's consumer-mediated because the consumer does it. So direct exchange is provider to provider. It's a full exchange of the record. Query-based is kind of those emergency settings where you just see all the emergencies I've gone through, but you're not seeing the full healthcare record. Consumer mediated, again, is where that patient is able to have better access to their information. Oftentimes in the ER, they're like, can I show you my health records? And we're looking it up on their phone, and it's still way better than nothing. So I'll take it. I would like to have honestly access to all 3 if I could. So I really dream of a day where we have a better interaction between health information exchanges, where each system can find a way to communicate with each other. And I think that would really decrease a lot of the redundancy within healthcare. We'll talk about this later, but the idea also of having a unified system that covers all the systems becomes complex too. Because if you remember earlier, we talked about comparing Planned Parenthood electronic record to Epic. One of the problems with the Planned Parenthood is they came up with one system to communicate with all systems, but that one system isn't tailored state by state. So you find you have a lot of things that you don't need in your record, versus Epic was more tailored. So some of the problems you might find with doing a single electronic healthcare record system is that this system might actually not apply to every area. So I don't dream that we all have the exact same system, but I do want the systems to communicate, because I think each area of medicine in each region of the United States actually probably might need some more ability to tailor their records to their needs, but I would like to just have them communicate to decrease redundancy and also decrease those phone calls to some poor doctor at 2 a.m. who tells me he doesn't have access to the charts and can't remember the patient. That I'd like to decrease in my practice. Let's just touch base with a quick assessment question. Which of the following exchanges allows the provider to discover health information about the patient, usually in unplanned care, such as emergency departments? I think you are all going to get this. It is query-based exchange. A query-based exchange allows the provider to discover health information about the patient, usually in unplanned care, such as the emergency department. So since I work in an ER, I get a lot of query-based exchange. All right, let's do another assessment question. Which of the following exchanges allows providers to receive or send secure encrypted patient information, such as patient summaries and laboratory data? All right, I think everybody got it. Directed exchange. In a directed exchange, providers receive or send secure encrypted patient information, such as patient summaries or laboratory data. This is my favorite because typically you get more of the picture. This is the patient that I can electronically be sent their records, and I have their full prenatal records, and helps my clinical decision making, and this will improve patient care outcomes. The more information I have about this patient's pregnancy, the better decisions I can make at the end of the pregnancy during an emergency. So information in healthcare matters for healthcare outcomes. I always hear people tell me, like, oh, I don't want to have to do anything like informatics. I think we all do a little informatics because it increases patient safety and improves our plan of care. All right, let's talk a little bit. First, I want you to think of a scenario that uses one of the above mentioned health information systems. Within my healthcare system, I mentioned that we use all three. Can you think of within your healthcare system how you use all three? Or do you find yourself only using one or two of these health information exchanges? All right, let's talk a little bit about databases. Databases can be used for clinical decision making. An example of this would be health preventative care reminders, computerized alerts, clinical guidelines, and health information databases. One of the benefits of these databases are that they can help standardize care. They can include screening, immunizations, guidelines for secondary prevention, diagnosis, specific treatment guidelines, drug management, dosage, alert for drug interactions, and drug formulary guidelines. And they can alert us about duplicate testing. So I think ours alerts us duplicate testing, and that's my favorite one. He'll be like, were you aware this test was run yesterday? And when I'm running busy, sometimes I'm not. So using databases can be a way to help minimize costs within the healthcare system and also help us better adhere to standardized care. This slide kind of reviews some of the barriers to the system. There are some challenges and efforts of standardization. One of them is the system interoperability and healthcare information exchange in the community settings. So basically, you might have a really good system, but its ability to communicate with another system might be diminished, such as I mentioned in the IHC system to the University of Utah, there's a 3-day delay. So there's many times that I think I have drawn labs that were drawn the day before because I'm like, this doctor saw this patient in clinic with high blood pressure. I'm sure they checked a protein, but the problem is I don't have access. So it's not quite as good as it could be. Because no community is the same. Work needs to be done on the interoperability of the healthcare systems and the implementation of health information technology across multiple settings. So basically, when we look at clinical decision making through a database, some of those barriers to this implementation comes from the differences in each practice setting. All right, let's talk about some of the technology systems we use. CPOE technology system allows a clinician to enter medication orders into a computer and transmit orders directly to a pharmacy. Now, for some of you new providers, this might be the only system you know, but when I started clinical practice, you called the pharmacist a lot and left a message on the phone. And that's timely. So this has the potential to enhance patient safety by ensuring that orders are legible and complete. And also, let's be honest, sometimes we all talk too fast. So many times the pharmacist will call me back and say, hey, did you say diflucan or fluconazole? And we'd be like, oh, diflucan for sure. It just increases basically the order to make it more clear because it's coming electronic and it's writing. So it's going to be a little bit better. The CDS system, paired with the CPOE system, provides prescription-related information on drug safety, allergies, and toxic reactions based on the laboratory results or drug-to-drug interactions. My favorite one about this is this would look at a patient's lab. So if you had a patient who had elevated liver enzymes and you were actually prescribing Tylenol, it'd put an alert and say, hey, are you aware that this patient's last lab showed that they're having some issues with their liver function? And as a provider, you might be like, I think I might go with ibuprofen. So it's a way to actually increase safety within the healthcare system. You're managing a lot of patients, and it's utilizing technology to help us be at our best. CPOEs have been shown to reduce the number of medication errors by, in some research, 37% all the way up to 80%. And I could see the 80%. Honestly, I can't tell you how many times when I'm running busy, I kind of rely on these type of systems. These systems are very complex, however, and they work better when an organization has identified goals and workflow needs. So I've had these technologies across different organizations and modalities. And my best one has been at the university because we have really put some time into the workflows. So I find the alerts that come up really help me understand. The alerts are really usually very, very apropos for what I'm prescribing. And one of the problems with these systems is you actually get what I call as alert fatigue. So if you get like 12 alerts and half of them don't matter, you kind of quit reading the alerts. So it's very key that when an organization puts a system like this in place that identifies goals, workflow needs, and doesn't cause fatigue from alerts. So when I was thinking about working at one of my other institutions, we primarily prescribed birth control, and the system would always send you an alert whenever you prescribed birth control for a patient under 18. Well, when you did this on 50% of your patients, after a while, you quit reading the alerts because none of them mattered. You want to really, as you make these type of systems, sway away from having alerts that don't matter because clinicians will start ignoring them. All right, let's discuss the operational application of health information systems. So first of all, there's going to be some changes as we better utilize technology. Human resources will be affected. There may be decreased needs for administration healthcare informatics. So basically, when I started practice, I used to have a secretary and she'd fax off all of my scripts and she would have loads to fax a day. Well, that's not necessary anymore because I send them from my iPhone. And that changes the actual human resources needs in a hospital setting. The adoption of EHRs, so electronic health records, HIEs, which remember the health information exchanges, and CDs, which are those databases, has facilitated healthcare management, improved coordination and communication between patients and providers, and reinforce safety. The focus of care management shifts from a community and a population focus. This brings up some challenges as we go from the individual patient to the community because we need a standardized system, and systems to be effective, must be adjusted to the individual community and the individual practice. So my take-home message when it comes to EHRs is they're as good as you make them. So if you, every day you're in practice, you notice an issue with your EHR, but you don't want to bother to email IT, you're not helping that system become as useful as it can be. So if you notice an issue, it's time to kind of talk as a practice like, hey, does everybody get this alert when this happens? Because it doesn't mean anything. Can we get that alert turned off? And that's going to make the electronic health record be more efficient in improving our quality of care administration and also make that electronic health care record really become a tool for us as providers. All right, let's talk a little bit about genetics. So they're super complex, I think. They are changing how advanced practice nurses manage and treat and manage and care for patients. One of the areas that I really find intriguing is pharmacological management in the future, which may depend on genetics and pharmacogenomics testing. Basically, they can do a microarray and identify individuals who are poor metabolizers, slow metabolizers, and normal metabolizers of a specific drug. If an individual is a fast metabolizer, think about it as a burn up that drug really fast. So there's going to be less of that drug, and they will need more of the drug for a therapeutic dose. So let's think of the type of drugs that we would actually bother to do a microarray of the patient to see if we should, what dose we should use. They're going to be expensive drugs, right? Like with birth control, it's fairly cheap. It's $4 a pack for Sprintac. Nobody could do a microarray on progesterone and estrogen to see how this patient metabolizes those hormones to see what exact dose they should have. But when you think of cancer medications and when you think of some of the more expensive medications, you might. So I want to give an example of a patient that I saw in the office. They had actually had microfiche and identified as severe hemophilia type A. The type of medication they were on is called Factor VIII, and this medication is $2,000 a dose. So guess what? Insurance at $2,000 a dose is willing to do a microarray on this patient and see what exact dosing this patient needs. And there's also some complications. If you're not therapeutic on your factor for a patient with severe hemophilia, you're going to have joint bleeds and brain bleeds. And so it's very serious to keep them therapeutic. So in the past, maybe they've gone on higher dosages, or due to cost barriers, not high enough of dosages. So on this patient that I saw with severe hemophilia type A, they did the microarray, and they'd actually done the microchip to figure out that he had this. And it turned out he was a fast metabolizer. So this child, instead of being infused every other day, is actually daily infused. However, looking in the future, he's now 8 years old and was diagnosed at the age of 1 and has had no joint bleeds. And this really good management of his complex medical system is probably due to the fact that we could look up genetically how he metabolized this medication and figure out the correct dosing for treatment. I think as some of these tests become less expensive, we're going to be able to do it in the future. Now, this is a lot of complex things. So one of the things I want you to think about is that healthcare information systems can help us manage these patients. This is a type of situation where you can use information systems so that you can make sure you find the right dosing and coordinate all this patient's care and get the right medication. In my clinical practice, the more complex the patients are and the harder the patients are, the more I find that I'm applying more of using technology in place. So when I started clinical practice, we used to have what was called the peripheral brain. And this is just kind of what we would do. We'd have a little notebook and you'd write down all the facts you thought you need to know. In case you forgot, you could look in your peripheral brain. Well, I'm going to tell you, medicine is so much more complex than when I started the field. There's no way I can write down enough things on 4x4 note cards that I will know how to manage a patient with severe hemophilia type A. I'm going to have to use a health information systems at that point. And I'm going to have to know what I know, but bring in those other systems so that I can better manage this patient. All right, let's talk really quickly about high fidelity simulations. This is used for practice and learning across many disciplines. It can help the advanced practice nurse maintain complicated skills and competencies. The clinical environment may not always lend itself to routine exposure to certain skills. At this point, the simulated environment becomes paramount to maintaining the skill. So I'm going to talk about the most basic one we all do, and we don't think about this as high fidelity simulation, right? That sounds very exciting, but really our CPR training we do is a great example of high fidelity simulation, right? As a provider in my life, I have done four episodes of CPR within a community. And that's, it's just not very common. 4 times I've actually been like, let's do chest compressions and given breaths to a stranger. However, I have it really down, 15 to 2, 2 to 30, a third to a half down in the chest on a compression. Why do I have this down so much when it's a skill I've done 4 times in like 10 years of clinical practice? Well, I'm able to practice these skills yearly at my CPR renewal course. Its simulation allows me as a provider to maintain a skill that I'm not always commonly using in the clinical setting. Okay, I want to talk for one quick moment and think about all the pros and cons of using a one database clinical decision-making system. So this would be one system for them all. A unified system would improve communication between healthcare providers. It would minimize repeat laboratory testing due to not having access to charts, and it would help standardize care. However, a negative thing about having a single database system is that it may not be well applied to different areas of the country and also different practices in different populations. It is a challenge to make a decision-making system that can be used in pediatrics and also oncology and women's health. Lastly, I want you to think about this. What do you think the solution is for our current electronic healthcare record system? Do you think the United States would benefit from a single system? Or would it be better to help individual systems interconnect? Should we have patients running around with thumb drives with their whole records on them and making it their responsibility to have their records? There's a lot of ways that we can use the electronic healthcare record system to better utilize services, but also to improve patient care outcomes. So right now, I want you to just think about how would you do it if you were put in charge of the healthcare system, and what innovations would you try to implement within your current practice to improve patient care? The take-home message from this lecture is to utilize your skills as an advocate for the individual patient and for the system to make improvements, to make changes that you hope to see in healthcare. This can be for improving access to care, to helping create a more cohesive healthcare information exchange system. But I think you're the future of our healthcare, and so I'm hoping through this lecture you learned a little bit more about advocacy and how to use technology within that advocacy, because I think you'll make the changes that will make all the difference in the future. Thank you so much for your time.